Okay, so the first thing we need to know when we're looking at EKG is actually how to figure out what the boxes are and what they are related to. So let's look at each little box. Each little box measures 0.04 seconds, or if it's going to the north and south, it's considered 1 millimeter of amplitude. Each large box measures 0.20 seconds, or 5 millimeters of amplitude. 5 large boxes, which means 0.20, 5 of those, equals 1 whole second. When you're looking at a 12-lead EKG, your leads are usually represented in 2.5 seconds periods. So one of the first things that we want to do when we're determining or we're evaluating a 12-lead is we need to determine the rate. A lot can be determined by the rate. Rates between 60 to 100 indicate SA node originated impulses, or at least it originated in the atria somewhere. Depending on the length, duration, and uniformity of the P wave could determine whether it's an ectopic area or if it's actually coming from the SA node. Many things need to be evaluated when we look at the rate. Rates of 40 to 60 could indicate AV junctional automaticity, and rates of 20 to 40 could indicate ventricular automaticity, which means that the SA node didn't fire, so now those cells have been are taking over for the pacemaker of the heart. When you're looking at the rate of an EKG, one of the first things you need to also look at is the P wave. You want to determine, is there a P wave for every QRS complex, and is there a QRS complex for every P wave? Is the P wave positive in leads 2, 3, AVF, and V2 through V6? Is it uniform in nature? In other words, do they all look exactly the same? Okay, the next thing we want to look at is the rhythm. We need to determine the rhythm before we can move on from any other part of the 12-lead interpretation. Is there a P wave before each QRS complex and after each QRS complex? If not, there could be underlying rhythms that we need to evaluate. Is it uniform in nature? In other words, do they all look the same? Is the PR interval consistent, or are there AV blocks that can be determined from there? Is the QRS interval normal, or are there bundle branch blocks, which could also create mimics? We need to identify underlying rhythm. So the 12-lead is designed to find ischemia and infarction as well as cardiac anomalies. They are not designed to determine underlying rhythms. Use a 6-second lead 2 strip to identify underlying rhythms. The third thing we need to determine when looking at a 12-lead EKG is axis. This is the direction of the wave of depolarization during each contraction of the heart. Look at the QRS axis on the 12-lead EKG, or you can figure it out by doing these steps. To determine axis deviation, you can use the hexaxonal system. This uses your limb leads 1, 2, 3, and AVL, AVF, and AVR. Leads 1, 2, and 3 should be a positive deflection if everything is normal. That would be a normal axis. Axis is the direction of the electrical impulse traveling through the heart. This does not measure contractility of the heart, only how the electricity is moving through the heart. This is normal axis deviation. It's measured from 0 to positive 90 degrees, and in leads 1, 2, and 3 should all be upright. This slide depicts physiological left axis deviation. It's measured from 0 to negative 40 degrees. In lead 1, it's going to be upright. In lead 2, it could be up, down, or equiphasic. In lead 3, down. Causes of physiological left axis deviation is usually due to age. This slide represents physiological left axis deviation. The 0 to negative 40 degrees gives you a chart that kind of gives you an idea of how to read your deviation. Lead 1 is still upright. Lead 2 is going to be up, down, or epiphasic. And lead 3 is going to be down. As you can see in this one, they have AVF in here, and AVF is also going to be down. This slide represents pathological left axis deviation. It's measured from negative 40 to positive 90 degrees. In lead 1, it'll be up. Lead 2, down. Lead 3 will be down as well. Some of the causes of left axis deviation, pathological left axis deviation, include left ventricular hypertrophy, conduction blocks, such as left bundle branch block or left anterior fascicular block, inferior wall myocardial infarction, pre-excitation syndromes such as Wolff-Parkinson-White syndrome, ventricular ectopic rhythms such as VTAC, congenital heart disease, like an atrial septal defect, endocardial cushion defect, hyperkalemia, emphysema, or you could have a mechanical shift, such as with expiration of raised diaphragm. In other words, you could have a shift of the heart, which is causing the deviation of electrical current through the heart. Okay, this slide represents right axis deviation. This is positive 90 to positive 180 degrees. Once again, lead 1 is down, lead 2 is up, down, epiphasic, and lead 3 is up. Some of the causes of a right axis deviation could be a posterior hemiblock, right ventricular hypertrophy, heart failure, pulmonary embolisms, or any type of arrhythmias. This slide is a representation of the extreme right axis deviation, so anything greater than 180 degrees. Leads 1, 2, and 3 will all be negative. The impulse is originating in the ventricles. The rhythm you'd usually see for an extreme right axis deviation is going to be VTAC. Okay, so now we're going to look at hemiblocks. A hemiblock is a block of one of the two fascicles of the left bundle branch. It's either going to be an anterior fascicle, posterior fascicle. You could have both of them blocked, and it also could include the right bundle branch as well. That'd be what they call a trifascicle hemiblock. Impulses can travel down any of the three fascicles. We're going to discuss in the next couple slides the difference between left anterior hemiblocks that include posterior and anterior. Okay, so on this slide what we're looking at is a left anterior hemiblock. As you can see, that it's the left side of the bundle branch, fed by the left anterior descending artery. Most common of the hemiblocks that you'll see. In the presence of an MI, mortality is 4 times greater. So what will you see on the EKG? First, you'll have a left axis deviation. You'll have a small Q wave in lead 1 and a small R wave in lead 3. Okay, so this is a posterior hemiblock of the left coronary, or the left bundle branch block. This is fed by the RCA and circumflex arteries due to its larger size. The left posterior fascicular is blocked. It should be assumed in patients with signs and symptoms of an MI. So what will you see on the EKG? Small R wave in lead 1, small Q wave in lead 3, and some of the clinical signs you'll see are JVD and pedal edema. So this slide depicts what we're going to see when we print out our 12-lead EKGs. Remember, when you print out your 12-lead EKG, let the entire printout complete. The very end of this printout is going to give you your axis deviation number. So you don't even have to figure this out by lead 1, lead 2, lead 3, or AVF. You can just look at the number. The big thing you need to remember are your degrees. So if you have anything between 0 and 90, everything is normal. Anything greater than 180, there's going to be issues. So make sure you're looking at that and don't tear those off and get rid of them. This chart's going to give you a rapid interpretation of your axis and hemiblocks. As you can see, it gives you your leads and it gives you the deflection from the isoelectric line that you're going to see with these. This is a great chart to have with you in case you're ever needing to figure out if somebody has a hemiblock. All right, so let's talk about bundle branch blocks and diagnosing bundle branch blocks. We're going to use lead V1. First thing you need to do is locate the J point. And then we're going to utilize the turn signal method if the QRS is greater than 0.12 seconds. So remember, down is to the left, up is to the right. So bundle branch blocks in the presence of an MI increase mortality by 4 times. So a left bundle branch block makes determining an AMI extremely difficult. It obscures the ST segment. When combined with a hemiblock, a right bundle branch block or a left bundle branch block are called bifascicular blocks. In the presence of a bifascicular block, drugs such as lidocaine, procainamide, amiodarone, and sometimes morphine will slow the conduction, resulting in complete heart block or asystole. Bundle branch blocks result in ventricular firing out of sync and could reduce preload. Patients with a wider than 0.17 second QRS usually have less than a 50% ejection fraction in the heart. Also, nitro could cause a massive drop in blood pressure for patients with bundle branch blocks. Okay, this chart is a good representation of the ups and downs of a right bundle branch and the down of a left bundle branch. It shows the widening out of the QRS complex. It's a good chart to look at if you're trying to figure out your bundle branch blocks and locations. All right, so the first mimic we're going to talk about is a left bundle branch block. Left bundle branch block will obscure this ST segment and make it very difficult to see ST elevation for MIs. Your QRS duration is going to be greater than 0.12 seconds. You'll have a dominant S wave in V1, and you'll have a broad monophasic R wave in the lateral leads, such as 1 AVL and V5 and V6. Absence of a Q wave in lateral leads, and a prolonged R wave peak time greater than 60 milliseconds in left precordial leads, such as V5 and V6. Okay, the next thing we're going to talk about is left ventricular hypertrophy, which is another one of the mimics. Most common cause of ST segment elevation in chest pain patients. And there's a couple different ways to figure out the criteria for left ventricular hypertrophy. The first one is going to be the Sokolov-Lyon criteria, which you measure the V1 S wave plus V5 or V6 R wave. You also have the Cornell criteria, which is the AVL R wave plus the V3 S wave, and anything greater than 28 millimeters in males is considered left ventricular hypertrophy, and greater than 20 millimeters in females is considered left ventricular hypertrophy. There's a modified Cornell criteria, which you just take the AVL, the R wave. If it's greater than 12 millimeters, left ventricular hypertrophy is present. All right, the next mimic we're going to talk about is pericarditis. This will give you ST segment elevation as well, but it'll be concave in all the leads with the T wave elevation. PR segment depression. Three things to distinguish between pericarditis and early repolarization. Your ST elevation is less than 25% the T wave and early repolarization. ST elevation and early repolarization resolves during exercise, and early repolarization is benign and should not be associated with any symptoms. So let's talk about the next mimic, which is going to be early repol or early repolarization. It's common in healthy young individuals. Appears as a mild ST segment elevation that can be diffuse, so all the leads. More predominant in your precordial leads, V1 through V6. The ST elevation will appear elevated at the J point. ST elevation is diffuse and concave. Absence of the reciprocal ST depression and large symmetrical T waves. So in other words, you don't have reciprocal changes in any of the leads, and you're going to have a very quick T wave that shows up. That would be indicative of your early repolarization. This is another representation of early repolarization. This is a classic way to figure it out. The previous slide was going to be your new way to figuring out early repol. All right, so let's look at some reciprocal changes in 12-lead EKGs. We like to use the mnemonic PALS for posterior, anterior, inferior, lateral, and septal. So if you have a posterior wall MI, you should have reciprocal changes in your anterior leads. An anterior wall MI, you should have reciprocal changes in your inferior leads. An inferior wall MI, you should have reciprocal changes in lateral leads. And a lateral MI, you should have reciprocal changes in your inferior leads or your septal leads. With a septal wall MI, you'll have reciprocal changes in your posterior leads. So in this 12 lead, you can see that you have ST elevation in leads 2, 3, and AVF. That's indicative of an inferior wall MI. You also have lateral reciprocation in your lead 1 and AVL. Okay, so let's look at this 12-lead EKG. So first, let's do what we're supposed to do. Look at the rate first. So our R to R interval, we look at it, it's about 100 beats per minute. There's a P wave before each QRS complex and a P wave after each QRS complex. So the next thing we need to do is figure out our underlying rhythm, right? So if there's a P wave, they're uniformed in nature, just one before each QRS complex. It's not delayed at all. It can be sinus in nature. Next thing we want to look at is our axis. So let's look at the axis on this one. We have in lead 1, it is positive deflection. In leads 2 and 3, we have negative deflection, which would indicate a pathological left axis deviation. Next thing we want to look at is our hypertrophies. Do we see anything that would be indicative of a hypertrophy? And no, there's no large no large R waves or S waves. So there is no left ventricular hypertrophy. The last thing we'll look at is our elevation. And if we look at this one, we do have elevations in lead 3 and AVF, which would be indicative of an inferior wall MI, with reciprocal changes in lead 1 and AVL. Okay, so let's look at this 12 lead and run through our steps. So the first thing we need to do, once again, look at the rate. So our R to R interval is roughly about 80 on the rate, because it is regular. Next, we want to look at P waves. Is there a P wave before and after each QRS complex, and is it normal? So there's no blocks noted. The P waves are uniform in nature. So this is going to be a sinus rhythm. Next thing we want to look at is our axis deviation. So if we look at leads 1, 2, and 3, our axis is all positive deflection over the isoelectric line, which means this is normal axis deviation. Next, we'll look at hypertrophy. There is no hypertrophy that is noted on this 12-lead EKG on the R wave or the S waves. Next thing is we'll look at elevation. So this patient has elevation in leads 2, 3, and AVF, which would indicate inferior wall MI, and as well has elevation in V4, 5, and 6, which would be a lateral. Also has reciprocal changes into leads 1 and AVL. So this patient has a positive inferior lateral MI with reciprocal changes in leads 1 and AVL. Okay, well, I hope you got something out of this 12-lead video. I know when we look at these 12 leads, it sometimes can be a little bit confusing on what we're actually looking at, but if you do the step-by-step method when you're looking at 12 leads, it'll really help you kind of get a good diagnosis of what you're dealing with. So I hope you enjoyed it. See you on the next one.